Hello, I'm Steve Russell from the School of International Development at the University of East Anglia. Stigmatisation of HIV has posed many barriers to dealing with the HIV epidemic, but expansion of treatment for people living with HIV has the potential to change processes of HIV stigmatisation. In this paper, we analyse how antiretroviral treatment, or ART, has changed stigma in Uganda, presenting findings from a qualitative study amongst 38 people living with HIV, 20 women and 18 men. They were recruited for the study from government and non-government ART providers. 2 in-depth interviews across several visits were held with each participant. Across societies, HIV has been strongly stigmatised, partly because it was fatal for a long time before treatment was available, also because it is contagious and a threat to others. More profoundly, HIV is often seen to pose a threat to the moral values and social order of a community. It is associated with disapproved behaviour and viewed as the responsibility of the individual, exposing people to blame and judgment. People living with HIV are judged to be immoral, promiscuous, irresponsible, untrustworthy and a danger to others, and more generally a threat to dominant social values. Increased availability and use of treatment in places like Uganda means some of these stigmatising characteristics are potentially being reduced. It is treatable and no longer a death sentence. People recover their health and, importantly, they look better and they can go back to work. However, analysis of stigma shows that underlying social processes which cause stigma, notably those relating to moral judgment and blame, are unlikely to be eliminated by treatment alone. Stigma derives from social and power inequalities. It is a mechanism whereby dominant values in society are asserted and reinforced, supported by those already with power. Patterns of stigmatisation examined in this paper are analysed with a focus on gender inequalities and how these shaped men's and women's experiences of stigma. Gender hierarchies mean that across societies, women usually experience greater levels of stigma than men. Stigmatisation reproduces patriarchal power structures. But men also experience HIV stigma because the condition threatens the features of hegemonic masculinity, such as physical strength, self-reliance, producing children, and being a successful breadwinner. Our own research findings were as follows. First, across the narratives, reduced self-stigma was clearly evident. The participants had managed to reduce feelings of shame and recovered their self-esteem and dignity. Several interrelated processes have reduced self-stigma, notably the recovery of their physical health and appearance, but also from support from health workers who encouraged them to think about their condition differently and more positively. They had a positive future outlook. Second, however, our findings also showed that anticipated stigma from others was still prevalent, and participants continued to conceal their status. 2 forms of anticipated stigma could be distinguished, patterned by gender. First, fears relating to renewed self-stigmatisation if others were to find out, notably a fear of gossip, which could threaten one's own sense of worth and dignity in the community. Now, both men and women expressed this fear of gossip, but for men this was their main fear. They feared losing their masculine status and dignity among others in the community, both men and women. Second, there was a fear of enacted stigma, notably fear of rejection by loved ones and fear that people would use your status against you. Female participants in particular feared a negative reaction or outright rejection from family members, friends, colleagues, and in particular, new intimate partners. Anticipated stigma is a strong indication that processes of stigma are still operating in this setting. The evidence indicates ART has not reduced underlying structural drivers of stigmatisation, notably gender identities and inequalities, and that interventions are still required to mitigate and tackle stigmatisation, such as counselling, peer-led education and support groups which can help people living with HIV reconstruct alternative and more positive identities.